My name is Dr. Neil Skolnik, a practicing physician at Abington Family Medicine in Jenkintown, Pennsylvania. I am also a professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University and associate director of the Family Medicine Residency Program at Jefferson Health Abington. I've been in practice for over 30 years, and in those 30 years, I've seen patients across all asthma severities. It is well established that asthma is characterized by two main features: inflammation and bronchoconstriction. Patients do their best to avoid their asthma triggers, but sometimes that's not possible depending on their environment. When patients experience symptoms such as shortness of breath, cough, and chest tightness, they often reach for their rescue inhaler. However, albuterol only addresses bronchoconstriction and not inflammation, an underlying cause of asthma symptoms and exacerbations. When I think about shifting the paradigm in asthma rescue, patients and even my peers need to understand that albuterol-only rescue is incomplete. We have historically treated symptoms with albuterol, not realizing that we need an asthma rescue approach designed to target inflammation and bronchoconstriction at the same time. Although the Global Initiative for Asthma, or GINA, first began recommending an anti-inflammatory rescue approach that could treat bronchoconstriction and inflammation in 2019, we lacked an FDA-approved option in the US, so we continued to rely on albuterol-only rescue to manage our patients' symptoms. With Airsupra, we finally have an on-label rescue approach designed to treat both inflammation and bronchoconstriction in line with GINA recommendations. Let me tell you a little more about it. Airsupra is the first and only FDA-approved anti-inflammatory rescue designed to treat bronchoconstriction and help prevent exacerbations. Airsupra is a combination of albuterol, a beta-2 adrenergic agonist, and budesonide, a corticosteroid. Airsupra was approved in 2023 for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older.
Important safety information. Airsupra is contraindicated in patients with hypersensitivity to albuterol, budesonide, or any excipients. Asthma may deteriorate acutely or chronically. Continued symptoms after Airsupra or increasing doses of Airsupra may be a marker of asthma destabilization and require evaluation of the patient and their treatment regimen. Airsupra can produce paradoxical bronchospasm, which may be life-threatening. Discontinue Airsupra immediately if paradoxical bronchospasm occurs. Paradoxical bronchospasm frequently occurs with the first use of a new canister of an inhaled formulation. Drugs containing beta-2 adrenergic agonists can produce clinically significant cardiovascular effects in some patients. If these occur, consider discontinuation of Airsupra. Beta agonists have also been reported to produce ECG changes such as T-wave flattening, QT interval prolongation, and ST segment depression. Therefore, as with all sympathomimetic amines, Airsupra should be used with caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Do not exceed recommended dose. Clinically significant cardiovascular effects and fatalities have been reported with excessive use of inhaled sympathomimetic drugs.
After learning more about Airsupra's data, it became apparent to me that Airsupra should be considered as asthma rescue therapy for all my adult asthma patients aged 18 years and older, regardless of their asthma severity or background maintenance therapy. Airsupra provides the symptom relief that my patients are looking for while helping to protect them from exacerbations which we, as providers, know they need. As a primary care physician, I see asthma patients across all severities. When I have a new patient with asthma come to the office, I consider starting Airsupra for their asthma rescue. When patients who are taking albuterol come into my office for a checkup, regardless of whether or not they're on background maintenance therapy, I evaluate whether it makes sense to switch them from albuterol to Airsupra. I found that my patients are very receptive to trying Airsupra because the concept of an anti-inflammatory rescue is simple to understand. Being a primary care physician means that every day is busy. So it's important that we always have the information we need to make the best decisions for our patients at our fingertips. Here's what I would like my primary care colleagues to know about Airsupra. It's an FDA-approved anti-inflammatory asthma rescue medication indicated for as-needed treatment or prevention of bronchoconstriction and to reduce exacerbation risk in patients who are 18 years of age or older. It is approved for use across all asthma severities as a rescue medication. It can be used regardless of a patient's background maintenance therapy. It is designed to address two key contributors to asthma symptoms, bronchoconstriction and inflammation. It contains the albuterol your patients are familiar with, plus budesonide, a corticosteroid. And use of Airsupra is in line with the 2025 GINA report that supports an anti-inflammatory rescue approach across all asthma severities. Airsupra has a patient access program that features a $0 copay card to make Airsupra accessible for the majority of commercially insured patients. My patients have found the copay card to be helpful. Thank you for listening to my thoughts on shifting the asthma care paradigm with Airsupra, the first and only FDA-approved anti-inflammatory rescue for asthma that treats bronchoconstriction and helps prevent asthma exacerbations. Please continue to listen for complete important safety information. I encourage my primary care colleagues to visit airsuprahcp.com to learn more about the mechanism of action and clinical data and to view the full prescribing information, including patient information, for Airsupra.
Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, as demonstrated by cases of anaphylaxis, angioedema, bronchospasm, oropharyngeal edema, rash, and urticaria. Discontinue Airsupra if these occur. Like all therapies containing sympathomimetic amines, Airsupra should be used with caution in patients with convulsive disorders, hyperthyroidism, or diabetes mellitus, and those unusually responsive to sympathomimetic amines. Beta-adrenergic agonists may produce significant hypokalemia in some patients. Decreased serum potassium is usually transient. Due to possible immunosuppression from the use of ICS, worsening of infections can occur. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Oropharyngeal candidiasis has occurred in patients treated with ICS agents. Monitor patients periodically. Advise patients to rinse their mouth with water without swallowing after inhalation. Hypercorticism and adrenal suppression may occur with very high doses in susceptible patients. If these occur, consider appropriate therapy. Decreases in bone mineral density have been observed with long-term administration of ICS. Regularly assess patients at high risk for decreased bone mineral density. Glaucoma and cataracts have been reported following long-term administration of ICS, including budesonide. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity in pediatric patients. The safety and effectiveness of Airsupra have not been established in pediatric patients, and Airsupra is not indicated for use in this population. The most common adverse reactions are headache, oral candidiasis, cough, and dysphonia. Airsupra should be administered with caution to patients being treated with strong cytochrome P450-3A4 inhibitors, which may cause systemic corticosteroid effects, short-acting bronchodilators. Concomitant use of additional beta-agonists with Airsupra should be used judiciously to prevent beta-agonist overdose. Beta blockers, which may block pulmonary effects of beta-agonists and produce severe bronchospasm. Diuretics or non-potassium-sparing diuretics, which may potentiate hypokalemia or ECG changes. Consider monitoring potassium levels. Digoxin, which may decrease serum digoxin levels. Consider monitoring digoxin levels. MAOIs or tricyclic antidepressants. Use Airsupra with extreme caution, as these may potentiate the effect of albuterol on the cardiovascular system. Use Airsupra with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. These are not all of the side effects for Airsupra. Visit www.airsuprahcp.com for additional information, including full prescribing information and patient information.